And with the work SAHPRA does, sometimes short notices are unavoidable. But we appreciate your patience, your indulgence. We will open up with the CEO of SAHPRA, Dr. Boitumelo Semete Makuketla. She will will open up and talk about this tool that we're launching, followed by Professor Helen Reese, who's SAHPRA chairperson. Prof. Hanali Meyer, the NICEC committee chairperson, will provide an actual presentation, followed by Ms. Mafora Matlala, who will talk about the tool and take you through the tool itself. We also have an expert panel who I will introduce after the presentations. We would encourage you to post any questions in the chat box, but we will have a Q&A session after the presentation. So if you want to hold your questions until then, you're welcome to. You're also welcome to post them in the chat box. We will start immediately now with Tumi. Please keep your mics muted until you pose a question, as well as your videos off for now, please, so we can ensure the integrity of the bandwidth. Thank you very much. Over to you, Tumi.
Thank you very much, Leanne, and to the colleagues from the media. We welcome you this afternoon, and again, thanks for being available in such short time. But we thought, before we issue a press statement that you will see this afternoon, as well as go live with the microsite that we've put together to really give feedback to the public on the COVID-19 vaccine safety and share with the public what are their observations and the reports that we've seen. We first engage with yourselves. And the reason for us doing this is to ensure that, collectively, as those who are responsible for communicating, such critical messages to the public, that we ensure that we provide you with sufficient detail for you to adequately and again, correctly share this with the public. We are aware of vaccine hesitancy. We are aware of the anti-vaxxers, but really today our focus is to say that, yes, while we have seen some reports, you'll see when the colleagues present, when Prof. Hanali Meyer presents, that there's a way that we go about doing the causality studies. So we really want to utilize this platform to provide you with as much detail as possible, so that as you put together, your reports, your stories, etc., you are then equipped with the information. We also wanted to ensure that we can share with you, some of the global best practices that are applied generally when one looks at vaccine safety, and also share, even other work that we do in general regarding vaccine. And that's what Prof. Meyer will also talk about, to say causality assessment is what we do with vaccines in general. And COVID-19 is then another product line that we are doing these assessments for. So we want to give you the full, perspective of the extent of the investigation that goes into assessing when we see an effect, how is it linked to a vaccine and is it not? What we also want to do is to ensure that we really communicate a positive message. As a regulator, we have, quite frequently shared that the benefits of vaccination certainly outweigh the risks. Some of the rare, the side effects that we've seen and the adverse events that we've seen are really rare. But because then, the public doesn't have the context, it then causes anxiety. But, with this pandemic and with knowing that at this point, vaccination has proven to be an effective strategy across the world, we want to ensure that we send out the right message, which is the benefits of vaccination truly outweigh the risks of not vaccinating, contracting COVID, and therefore then succumbing to the disease. And so the purpose for today is that we will share with you this microsite before we go live with it this afternoon. What you will note is that also if you visit other regulators' websites, you will see something similar. And so we have ensured that, as we put this, we learn from others, they learn from us, and we share in terms of some of the results that we see, because some of them are not unique to South Africa, they're being observed in other countries. and it's really about putting them in context. So we thank you for making the time to engage with us this afternoon, and we really are open for questions. As Leanne said, we have our panel of experts that we work very closely with, who will also take questions after the presentations. Thank you. Over to you, Leanne.
Thank you, Timmy. Our colleagues just reminded me I hadn't introduced myself. I'm Leanne Collingridge of Conversations Media. I'm assuming I know most of you, which is arrogant, but it's me. So next up is Professor Helen Reese.
Thank you very much, Leanne, and to Tumi, and good afternoon, everybody. Thanks so much for coming on. This is an incredibly important thing to do because there are two words that we need to grapple with. One is the need for transparency from scientists, from regulators, and from health departments. We need to be sharing information and have the public's confidence that we're being honest in the sharing of that information. So that would be the first real concern, and having a website like this, having a reporting mechanism like this is one of the steps that we can take to do it. But the other one is misinformation. I've just looked at a website where somebody is on a website and with a lot of focus, talking about having had a serious but rare adverse event in a clinical trial. But in fact, the leader of that clinical trial has said, no, indeed, that person had a placebo. So, you know, first of all, the person concerned needs to be counseled and supported, clearly. But it's very important that the wrong information then doesn't go out. And that's where the media becomes incredibly important. Tumi mentioned vaccine hesitancy, and I think you've all been looking at the many surveys that are coming out now. Now, from what I've seen on average, well over half of our population are saying that they really want to have vaccines. But there's about another sort of 35–40% of the population, depending on which one you look at, 30–40%, who say probably yes or probably no, or I'm not certain. And these are the people who we really need to talk to. We need to reassure those who are confident in having vaccines that we're measuring safety. But particularly, one of the commonest reasons that people say, I'm not sure, is, did this happen too quickly? Do we really know if these are safe? So we can share all the safety data we've got from clinical trials, but what we now need to do, which is the much bigger data set, is share the data that we get once we start to look at the effectiveness and safety when we roll out vaccines into the general population. It's going to be incredibly important that we monitor this. And as Tumi also said, that we do it with all our global partners, so that anything that's incredibly rare, that does occur, that is associated with a vaccine, can be evaluated, and causality can be assessed accurately with global data sets. And then we can be honest with the population about what we know and what we don't know. But just to say at the moment, the severe side effects that we've seen with any of the vaccines that we've seen are extremely rare. The side effects, if you like, and the sequelae and the outcomes of COVID infection, I don't need to tell all of you, are very, very severe, including and growingly concerns about long COVID, which is something that to date we haven't here in South Africa or the African region paid as much attention to. But as time goes on and more people or more young people get COVID with those kinds of sequelae, is something that we also need to think about, as well as the severe illness and the deaths that we undoubtedly see. With that, I'll stop, and thank you so much for arranging this webinar.
Thank you, Professor Reese. We do have a question from Christian from Network 24, but Christian, if you could just, we have noted that question, if you could just wait for the answer. We will go first to all the speakers. So next up is Professor Meyer, and once we're done with the presentations, we will then proceed to answer questions. Thank you.
Thank you. Can you just let me share my screen? At the moment, it's disabled. Thanks.
I've shared it, Professor. Okay.
It still says disabled participant screening on my side.
Okay, hold on a second. Mbali, can you?
Please try it now, Professor. I've just allowed it to.
Okay. It's fine now. You can tell me if you could see it. Can you see my screen?
Yes, we can.
Okay, good. Good, thank you very much, and welcome to everybody, and thanks for taking the time to attend this very important information session. So I'm going to talk about the causality assessment process, and it might seem very theoretical and technical, but I think it is necessary to share this with the media, as I've had many questions regarding this in the last, I would say about 3 weeks, where people don't really understand what causality assessment means and what are we actually doing and how do we get to the final outcome of a case that's been investigated. So I'm going to try my best to make it as simple as possible. And yes, we'll be able to answer some questions afterwards. So just to paint a picture, this is the adverse event following immunization reporting process. So I just want to quickly take you through it. So firstly, the case is being reported. Thereafter, we determine what should be investigated. We then go ahead with the investigation. From there, the information, when all the information is collected, is then submitted to the National Immunization Safety Expert Committee, and they then conduct the causality assessment, after which feedback is given to the relevant parties. So I'm going to use this now as a way forward to explain in more detail what happens. So as you can see, this is now when a case is being reported. So all adverse events, we encourage people, the public, everybody to report all adverse events because we need to monitor the safety of the vaccines. So it's not to scare people. I've said it now multiple times. It's not to scare people. It is actually to show them that we want to make sure that the expected adverse events from the clinical trials, we see the same rates as we are using the vaccine now in the larger population. So this can either be done with the MedSafety app by healthcare workers as well as the public, or alternatively, the healthcare workers will complete a 2-page form. So I want the media to actually see this is the form that's been completed. So this only collects basic information. So when we then, after this step, within the provinces, they then would look at the adverse events being reported, and the ones at the top of the screen, those are the minor events. So these events are the ones that we are expecting to see, and they were the ones identified in the clinical trials. And as Professor Reese and referred to this as well, these are the minor events, and they subside by themselves, usually within 2 to 3 days. So they are not being investigated, but we want to know about them so that we can make sure the vaccines remain safe. So in other words, if you have experienced swelling or a headache, a mild headache or a mild fever, nobody is going to phone you to find out whether you still have a headache unless you report it as a serious event. So now let's go to the serious events. So it's these ones here at the bottom. And as you can see, there's also space for reporting other events that's not necessarily listed in this little block. So this information is being reported on this form or alternatively on the MedSafety app. So these are the ones that we do not expect to see. And that's why we need to, and they are also more severe. So in other words, to use a simple example, the swelling more than 5 centimeters. So that's something that we do not expect to see. But if it happens, then we need to investigate it. So these ones are then marked for investigation. So to go to the next step then, they are then forwarded to the district investigation teams within the provinces and within the relevant districts. And you will not be able to read this, but just to show you that this is a 6-page form collecting detailed information about the case. So within this, all these questions that's being asked, additional information is being collected as evidence. For example, clinical records, reports from doctors or from the pharmacist, or even from the family. So in some cases, they also need to do an interview with the relevant family members or with the patient or the person himself or herself who experienced the adverse event. So when all this information is now being collected and it's complete, then it's submitted through the district then to the National Immunisation Safety Expert Committee. So just to, again, explain what causality assessment is. So we do causality assessment because we want to determine, what was the cause of this event being reported. So causality assessment is not to specifically prove or show that the vaccine didn't cause the event, but also we want to know whether the vaccine did cause the event. So this is a systematic review of all the data being available about the specific case to determine whether there is a likelihood of a causal association between the event and the vaccine. So when we refer to a causal association, it means a cause and effect relationship between the causative factor, which we now take as the vaccine, and then an outcome with no other factors intervening in the process. So we need to determine whether there are any other factors that could be the cause of the event. And then very important to remember is not to just assume from the start or throughout this whole process, just because the event followed the vaccination, there is definitely a causal relationship and it was caused by the vaccine. Now I'm going to take you through the causality assessment process. So, sorry, just to go back. So on the left hand of the screen, you will see this is the methodology that we are following. So it's a well-known methodology recommended by the World Health Organization. There is a link as well, so you can actually go to this website and look at it if you are interested in looking at how this is actually being conducted. So to take you through the process, so the first step is we look at the eligibility of the case. So this is very, very important, and it's so important that people should understand and know this. So if we don't have all this information available from the case investigation, then causality assessment cannot even start. So if you don't have this information available and you don't have a diagnosis to start off with, then the case is completely ineligible. If you don't have a specific patient or a specific vaccine, for example, you cannot even start off with step 1. So then it takes you to step 2. So step 2 is made up of various steps, which systematically then guide the assessors to collate all the available information within this case, within this assessment. So for each one of the steps that I'm going to show you now, you need to refer back to the information that's collected by the investigation teams. So the first one is to determine if there is a strong evidence for other causes. So for example, in this case, you would then look at if there is an autopsy report, what does the autopsy report say? If this person died of COVID-19, do you have evidence of that? Do you have a COVID-19 positive test? So this is just 2 examples. Then the next step to look at is, or question to ask, is there a known causal association with the vaccine or the vaccination? So there we look at the vaccine product. So in this case, you would then look at what has been reported in the clinical trials. What are common adverse events being reported? Then we also look at safety data from across the world. Has this been reported anywhere else in the world, for example? So could this be really a cause of the product? And for each one of these, what I didn't mention, so when you tick these blocks, so the first one is yes, the second one is no, and the third one is unknown, and the last one is not applicable. So when you tick one of these yes, you have to provide evidence of that. So you can't just guess and say yes or no. You need to provide evidence in this space. And because this is it's an online tool, it will not allow you to continue with the process unless you can provide the necessary evidence. The next question is whether there is a causal association with the vaccine with regards to the quality of the product. So this is a very rare instance where we would see that, and I've explained it also in one of the other talks, that in South Africa we have another step. All the vaccines batches coming into the country, all being manufactured in the country, is then tested for quality by the National Control Laboratory in Bloemfontein. Then the following step is there a causal association with the vaccine or the vaccination with regards to immunization error? So as you can see here, there are a number of questions. So we also look at the program of vaccination. Did anything go wrong? Was the cold chain maintained? How are they administering the vaccines? What kind of needles are they using? To make sure that there was no human error involved in this event. Then the last one is to determine if there was possibly a stress-related response involved with this event. So with COVID-19, where we are vaccinating a lot of adults, this is something that's been seen across the world. So, for example, people who are petrified of needles, petrified of injections, or people who are feeling uncertain about the whole process, but they've been convinced and they want to have it done, and then they're also anxious on the day that they would, for example, faint. And then when a person faints, there could be certain symptoms that could also be, people could think, well, this is an anaphylactic reaction. So all the vaccinators are also trained to be able to differentiate between what is an anaphylactic reaction and what is a stress-related response, because the management of those are vastly different, to make sure that they are able to manage these cases at the vaccination sites. Then the next step is to determine whether the event took place within the window of increased risk. So, for example, say for instance, there's an anaphylactic reaction reported 6 weeks after the vaccination. It wouldn't be within the window. So immediately you would rule out the possibility of an anaphylactic reaction because it is far beyond the window of increased risk. Then the next one is to determine if there's a strong evidence against a causal association. So is there any evidence in the literature which tells you that this is not possible? So it's against a causal association with this specific vaccine. Then the last step within this section is where you look at any other qualifying factors. So I've just put 2 examples in here to illustrate also why we need all the information before we could start with the case. So where we then look at whether there are any comorbidities that could have contributed to this, whether the person has been on any medication, were there any other allergens, involved, especially in the case of an allergic reaction. And within this section, we also look at the expected or the background rates of this particular event in the unvaccinated population. So we look at the background rates, and if we see that the rate at which this particular event is being reported now in vaccinated people is much higher than what is expected in the unvaccinated population, then that would be a signal, and we need to look at that specifically then further. So once you've gone through all these steps and answered all these questions, then the software takes you through this review process where you now go back and you review all the steps that you have already completed. And as you can see, there's a mandatory path as well. So even if you get to the first question and you would say this is a coincidental event, it takes you through this whole path again to make sure that it's not classified as a coincidental event and that there could be, some other causes for this particular event. And then the final step would then be to classify the case. So I'm going to take you through these slides now that I've gone through in the last media review as well. So you can also go back to that, but just to illustrate. So if there is then a causal association with the particular event, the event or the case would then be classified as either a product-related reaction, so it's caused by the product, or a quality-related, defect-related reaction, which I have explained. So something wrong with the quality of the product itself, or a stress-related reaction, here on the right, and then in the middle here, whether it has been caused by a program error-related event. So that was there anything, within the immunization program that could have caused this event? For example, say, failure of the cold chain. And then the next category is then the coincidental event. So this means that this event, although it happened after vaccination, it was not caused by the vaccine. So for example, in the case where a person had multiple comorbidities and the person died because of one of those comorbidities as a coincidence to the vaccination. So it's not being caused by the vaccination. Then this is an example of an ineligible case. So it actually relates to one of the other slides. So I'll get back to this, but this just shows you then if we don't have enough information available, then it's impossible to conduct a causality assessment. So if you just get a report of someone who passed away at a certain age and maybe a gender, but you don't have any further details, then you will never be able to determine what the causality of the case is. Then there's the indeterminate case, classification. So when cases are classified in this class, it means that although there is a temporal relationship consistent with this event, there's not sufficient evidence and definite evidence to classify this case. And then these cases could then be potential signals. So if we then see more of these cases in future, then it might indicate that we need to do specific studies designed specifically to look at these events. So it could be new, new adverse events as well. And these ones are only determined when the vaccines are rolled out in very, very large populations. And for South Africa, our data is also combined with the data from other countries in Africa, so that we have large databases to be able to detect specific potential signals. Then the last category is then when the case is unclassifiable. So this is actually where this example is coming in. So if, like I said, if we don't have this kind of information available, then the case might be completely ineligible. So you cannot even start off with the causality assessment. And you have to close this case as being unclassifiable until maybe information becomes available about this case. Another reason why a case could be unclassifiable is when you are able to proceed with the causality assessment, but when you get to the end of the assessment process, you don't have sufficient evidence available, or there might be certain evidence that you would still need to make a definite decision about the causality. For example, if you don't have laboratory results available, say for instance, someone dies of COVID-19 2 weeks after vaccination, and you have some clinical reports from the hospital, so you can see this person and the doctor might have written COVID-19, but you don't have the laboratory results available. Then you can't say, well, definitely this person died of COVID-19. So this is actually very reassuring, to make people understand that we don't just make a guess and say, well, this looks like this or it looks like that. We work, only based on evidence to get to the final causality assessment classification. So just to, in conclusion, to reinforce that for causality assessment to take place, we need these three very important parts or sections, of which the first one is that there must be a case investigation. So if someone phones in or put something out in the media and say my relative died of COVID-19, died after the COVID-19 vaccination, 3 days post-vaccination, but it's nowhere reported, then there's nothing anybody can do about it. So to start off, we need to have a specific diagnosis, and that is based on this information being collected throughout the investigation. And then the last one, obviously, all the details, as I said, and the evidence must be available. So I hope this has provided a bit more clarity on how this is actually conducted, and that, it's a very rigorous process that's being followed, and to make sure that when we finally assign causality, we are 100% sure of what we are saying. So thank you very much for listening, and acknowledgement, yes, to everyone who's worked very hard in the last 6 months or a year to strengthen this whole process. Thank you.
Thank you, Professor. We will now move to Ms. Mafora Matlala, who's SAHPRA's pharmacovigilance manager, to take us through the actual reporting microsite.
Thank you very much, Leanne, and good afternoon to everyone. I'm just going to share my screen and take everybody through the microsite. Okay, Leanne, kindly confirm that you can see my screen.
We are seeing your screen, thank you.
Okay, thank you. So this is the microsite that SAHPRA has developed as a tool for reporting the adverse events following immunization that we have received in the system, so that we can show the public. So this is the landing page of the microsite. So on the landing page, when you come in, then there will be a disclaimer that will pop up. And basically the importance of this disclaimer is to ensure that anyone who's reading this information is aware that the information that is on the site is not necessarily causality assessed, as Prof has highlighted, unless otherwise specified. Therefore, the events that have been reported here, they are not necessarily having a causal relationship with the administration of the vaccine, but it's just to share what we have received in the system with the public to say, this is what we're seeing in our system. So on the introduction page, basically, we're giving a bit of background with regards to the AEFIs, what are they, and the classification thereof that talks to the AEFIs to say they can be classified or grouped into 5 different groups. And these are some of the things that Prof has actually alluded to when she was talking about causality assessment. And then also indicating the mild that she indicated as well to say they actually resolve within 2 to 3 days following vaccination. And then going down on the introduction, we also relate some information to the Sisonke phase 3B clinical trial study that took place and say, in this system, we only reporting the adverse events that actually started with the national rollout on the 17th of May. Anything that relates to Sisonke, more information, you will be finding it on the link to the Sisonke site. So if you press here on the link, then you are able to go to the Sisonke site where you're going to get more information relating to Sisonke study. Okay, I just need to minimize this part here and go back to my screen. Oh God, okay.
Flora, could you speak a little bit louder into the microphone, please?
Okay, maybe let me put in this right down. Okay. Okay, am I audible?
You are. If you speak a bit more, we can determine how it, what the quality is.
Okay.
That's better.
Yeah. Technology is working on me. How do I go back?
Maybe just click out of that and
close the tab that you're in.
Close the tab, yeah.
you can see your tab there. Yes.
Okay.
Can you?
On the top left, it says
there's a tab.
Top left.
Top left, where it
Yeah,
says advertisement, click there.
No, I can't see anything. Okay. Apologies for that. I will reshare my screen. Share screen. And then there we go again. Share. Okay, so this is where you will go then on the Sisonke. Okay. And then as you continue on the introduction page, then you will go to a section where it talks to the national rollout as indicated. And here we're relating information that actually is on the professional information and the facts sheet for the population to say, if they want more information on the professional information and the facts sheet, then they will be able to get it. So if you click it here, it's going to take you to the facts sheet, and then here it's going to take you to the professional information. Moving down, then we took into the SAHPRA working in relation with the National Department of Health and the EPI, as Prof has already alluded to that. So we're just giving a bit of background with regards to the working relations between SAHPRA, the EPI, National Department of Health, and the NICEC committee. And then further down, we're thanking everybody who contributes to the monitoring of COVID-19 vaccines and also to the reporting app that we're using, but I will talk to it more when we go to the next step. So this is basically the introduction page, which is the landing page that one arrives at as they come to the microsite. Then the next step is on the definitions. So on the definitions, we provided a number of definitions. that are more related to the adverse events following immunization, so that the public would have an information. What is it that we mean when we talk to causality assessment, as Prof has alluded? What is it that we mean when we talk about pharmacovigilance, and what is a safety signal? So as you click on this, you will get more information regarding to this. And what we've done is that we've tried to provide it in a more understandable language so that the public would be able to understand what we're referring to. Then the next step is how to report. On information on how to report, basically it talks to the ways that are available for reporting, and Prof has also alluded to them. And one of them is using the MedSafety app. And the MedSafety app, when you press here, then it provides you more information with regards to the MedSafety app, what it is, and then where can you get it. And then once you press on the find out more, then it takes you to the site where there's more information regarding the MedSafety app. The second way of reporting adverse events following immunization, we advising that the public can also visit their nearest health facility if maybe they don't have access to a smartphone or using the MedSafety app. And then through the health facility, then they should be able to report the adverse events following immunization. And lastly, we have a call, COVID-19 hotline that they can call, and then we have provided the number and then the option to make it easy to report the adverse events following immunization. So maybe what's also important is to note that on each and every page, the disclaimer that popped in the introduction, we have included as well to say it's important to note that the adverse events following immunization that are reported on the site, they have not been causality assessed unless they are specified as previously highlighted. And then we have a fourth tab that talks to doses that have been administered. And basically this tab, it's a link to the National Department of Health site where it provides information about the doses that have been administered. So this is live information. And if you go through this, there are a number of slides. There are about 10. I will not be going through them because this is publicly available. But what we have done is that by linking it to the National Department of Health, the public would be able to get all the information relating to COVID-19 vaccination and the adverse events under one. So this is how we have decided to go on with it. And then the next one, it will be adverse events that have been reported. So on the adverse events that have been reported, okay, so the disclaimer will also come on the adverse events that have been reported. Okay, so, okay, now I'm back to my problem. Dogozo, please assist. Okay, resume sharing, okay. So on the adverse events that have been reported, I guess this is the most important page that maybe we will spend quite a number of time on it. So what we have done, because when we receive this information, we need to do what we call data cleaning and ensure that everything that we put here has been looked through quite thoroughly. We have decided to provide the information to the public as of the 31st of July, while we're still cleaning the other data. So this is from the 17th of May, which relates to the national rollout as indicated, and up until the 31st of July. So this site will be updated on a weekly basis, as and when we go, then more information and the dates will keep on changing as we go. So on this side, what we provided basically, we provided the number of doses cumulatively, that is for Comirnaty in combination with the J&J vaccine that were administered by the 31st of July 2021, and together with the number of adverse events reports that we have received in the system. So we have therefore calculated to say, what is the percentage of the adverse events reports that we have seen for the total adverse for the total doses that have been administered so far. So we have seen that it's 0.02% of all the doses that have been administered. And then we also stratified it according to vaccines. So this will be for the Comirnaty, which is the Pfizer-BioNTech, and then this side it will be for the Janssen vaccine. And if you look at the percentage, they are more or less the same. Then moving down on the adverse events that have been reported, we have also provided the number of doses that have been provided per province as at the 31st of July, and also looking at the percentage of adverse events following immunization that have been reported per province. For instance, if you look here, we've got the Eastern Cape with 930, 583 doses that have been administered as at the 31st of July. And the reports that we have received in the system for Eastern Cape, it's actually 0.02% of the doses that have been administered. So you need to read this together. For Free State, it will be the same. And if you look here, the percentage are more or less the same for most of these provinces, which is in line with what we are highlighting at the top cumulatively. And as we move down, then we've got the adverse events following immunization per gender. And the gender one is straightforward to say females have actually reported more reports compared to males. And we also have about 46 reports that were unknown, but this also is as a result of the vaccinations that have been taking place to say women, they have been vaccinated more compared to males. And then the last one on my right is the number of adverse events following immunization that are distributed by age and by vaccine. So this turquoise, it will be indicating the COVID-19 Janssen, and the blue is for the Comirnaty. So for age group 18 to 29, we have seen that there's 66 reports that are relating to Janssen vaccine compared to 41 reports. But for 60 to 69, we have seen 339 reports for Comirnaty compared to 17 reports that have been received for the Janssen. And this basically talks as well to the vaccines that have been administered in different age groups. As you may know, most of the Comirnaty were actually administered to the elderly by the 31st of July, compared to the J&J, which was more for healthcare professionals and the young people. So this is how you can look at this information as well. Then I will move to the next tab that talks to the frequently reported AEFIs. And as Prof has highlighted, the top reported AEFIs that we have seen in the system, they are non-serious and they are mild. And then if you look at this, the first one, it will be headache. And this has been stratified by the vaccine as well. You can see that we've got about 229 reports on headache related to or reported on Comirnaty, and 119 reports reported for Janssen. And the next one, then you'll see it's a local reaction. And if you look at this, these are all minor reactions, and they resolve within few days, as Prof has also indicated. And then I will move to the next tab where we talk to serious adverse events following immunization. So on the serious adverse events following immunization, we have tried to provide a bit of narrative into what are serious adverse events following immunization. We have put a definition as well of serious adverse events following immunization, but on this page, because we specifically took into adverse events that are serious, then we have decided to provide a little bit of narrative, but we did not leave the non-serious, because we also look at the non-serious, and with the non-serious, we ensure that the rates are low and acceptable. So all in all, we monitor both the non-serious and the serious. But then when it comes to the serious, this is where mostly causality assessment is more concentrating, as Prof has highlighted. So we also have what we call the AEFIs. So the AEFIs are the serious cases, but these are of special interest. And then we also need to do causality assessment on them. And then if there's a need for further investigation, then we also need to do investigations on them. So with the serious AEFIs, basically we're talking to the ones that are medically important, the one that requires hospitalization or prolongs an existing one, life-threatening, or the ones that result with birth defects, or the one that actually result in death. So as this is our first publication on the microsite, we have concentrated more on the death cases, but in future we will be providing more information on other serious cases as we move and do more of causality assessment. So with regards to the death cases, I've seen a question that relates to the death cases, and I'm hoping this will actually answer the question. So for the reporting period, we know that about 7.1 doses of COVID-19 vaccines had been administered in South Africa, but then furthermore, we have received 53 death cases for that period. And then this is actually 0.007% of all the doses that have been administered. And on the 53 cases that we have received, 21 cases are still under investigations, but we can talk to the 32 cases that have been investigated and causality assessed. So under the 32 cases that have been investigated and causality assessed, 28 of these cases were found to be coincidental, and Prof has actually provided a thorough details as to how the classification goes and then what each classification means. So 28 of them were found to be coincidental. And then out of these 28, 6 of them, unfortunately, they had COVID-19 diseases. And then the remaining 4 cases were unclassifiable due to inadequate information, as Prof has highlighted that in cases whereby there's not enough information, that we are unable to classify the cases. Then I'm going to the tab that talks to causality assessment. So on the tab that talks to causality assessment, we're providing an education to the public on this tab, basically on what Prof has actually alluded to. So we're providing a definition to say what is causality assessment and how does causality assessment basically assist us, and what is the process that needs to be followed with regards to causality assessment. And I will not be going into much details because Prof has thoroughly looked into, spoken into this topic. So we have put what Prof was actually saying in this section so that the public would be able to have more information regarding the causality assessment. And then moving then, we have case selection for causality assessment. What are the cases that we look at? These are the serious cases. And then furthermore, we also look at the non-serious as well. But then these ones, we know that they take few days and then they resolve. However, we still look at them if maybe there's a cluster of cases or anything of that nature. And then also the signals as well. And then for a case, to qualify for causality assessment, what should be there? Prof has actually spoken to this and indicated that there should be investigation completed, specific diagnosis, and details and evidence. And then furthermore, we're saying, what is it that the member of the public can actually do in order to provide sufficient information to inform causality assessment? So exactly what Prof has highlighted to say, what kind of information do we require? Then we indicate that we want personal details of the vaccine recipient, and we being specific to say this is at the minimum level that you can provide the information that you should provide, and then the name of the vaccine, the AEFI that have been experienced, coexisting medical conditions, any other medications that were taken, including the traditional medicines, any lab results if they do exist, and post-mortem in case where there's death. And then the last step on this, it talks to classification of AEFIs. And Prof has actually explained what we mean by consistent with causal association, indeterminate, inconsistent, and classifiable. So more information has been provided here. Our second last tab is the FAQs. So the FAQs basically It's as a result of the social listening that we do in collaboration with the GCIS, and the questions that we receive from the GCIS together with National Department of Health. We try and provide clarifications on the questions that we receive, and this is where the public can get more information as well. Lastly, we have a tab that talks to more information. So under more information, we've got links to different sites, and then we'll be adding more as we move. That will provide more information for the public with regards to information on COVID-19 vaccines and any other information like the fact sheets that we have placed here, the professional information as well. Thank you very much, everyone, for listening. Leanne, you may continue. Thanks.
Thank you very, very much, Mafora. So now we are going to the part of the presentation which I think you're most looking forward to. It's the questions. To answer your questions will obviously be the 4 members of the panel, but they are joined by Professor Mark Blockman, who is chair of SAHPRA's Pharmacovigilance Advisory Committee, Professor Rose Burnett, who's from Sefako Mahato Health Sciences University, Dr. Kerrigan McCarthy, and Professor Johnny Peter, both of whom are members of the NISAC committee, and Marion Schoenfeld, Ms. Marion Schoenfeld, she's from the EPI Pharmaceutical Policy Specialists. So we will go immediately to questions. As you know, I'm sure you're watching the chat box. We have had several from Christian from Netwerk 24. I will read it out. It is addressed to Professor Reese, but she's not the only one who necessarily needs to answer. And he's asking, he has 2 questions. I'm going to read them both. His first question is, what was found with the investigation into 29 deaths that were reported after people got vaccinated? And he wants you to please provide details on that specific investigation. The second question is also to Professor Reese on the registration for 18 to 34-year-olds, which opened today. He's saying that seeing that people in this age group do not have such a big risk of dying from COVID-19, why would you encourage them to get vaccinated? Let's take those 2 questions for now. Nelly Siwe, we see your questions and we will get back to this next round. Thank you.
Thank you very much. I think Flora just did show some of that data. So on the deaths, I'm going to ask Flora and Tumi and Hanali, any of them to actually reply. But I think just an overarching comment about deaths, and Hanali did outline this very clearly. When you roll out millions of vaccines, which is what we've already done, and billions of vaccines around the world, you are rolling them out. And remember, our first priority cohort after healthcare workers were people over 60. So once you roll out into people who have comorbidities, are older, etc., you must anticipate that some people are going to pass away just because of nature. The differentiation is there an association, or is this unfortunately just life? And that's the very important part. And the one thing I would appeal is there was a headline about this, which the content was very good, but the headline could have been misinterpreted. And one of your comments later on says, do you think we could be stoking the other kind of viewpoint by giving this kind of data? Because I think the headline said something about that of the 29 or 28 deaths couldn't be linked. So we must be very careful in the way that we actually present the data, because the causality is, you could say, linked, but when you put it in that way, I think it gave a misleading response. So I think I'll hand that one over, but I'll just answer the 18 to 34-year-olds and why we're doing this. Well, there are several reasons. You're quite right that we started off with the primary aim of our rollout was to prevent severe disease and death. And that meant, and hospitalisation that obviously goes with that. And that meant that we obviously targeted people who were over 60, many of whom would represent a large number of comorbidities in the country. And by coming down in age group, we were able then to capture also the most likely people to have these comorbidities. So that was why we started in that manner. You're quite right that in this age group, we're going to have far fewer comorbidities, and the prognosis if you get COVID-19 is much, much better. However, one of the other things that we want to do, we still need to get those numbers up, by the way, incredibly important. We have not hit targets in over 60s, over 35s even, and over 50s. We have not hit those targets. We haven't hit targets for teachers, and we haven't hit the targets for healthcare workers. So that is still very much on the table, and we have to hit those targets. But the other thing that we want to do with time is to get more population immunity. That will occur in two ways. One is through natural infection. We know that many people now, if we do sero surveys, we know that many people have already actually been exposed to COVID-19 with or without symptoms. So that will give them a level of immunity. For how long, we're not sure. And if it was with an earlier variant, how well protected against new variants, again, we're not sure, but we do see reinfection, and we know that. So that will be one way, but the other way is to get vaccination coverage. If I gave you an equivalent experience, we know that measles is one of the most infectious diseases that we have in the world. And it's deathly, it can be deadly for children, particularly under 5s. What do we have to do to stop measles transmission? Because it's so transmissible, we have to get antibody levels up in that risk population of the under 5s up to 95% and more. And we do that through vaccination, even in the poorest countries. So we know that when you have a very transmissible virus, you have to get population immunity up to very high levels to stop transmission. So one of the reasons that we're now going down to the younger age groups is to start to try and get more population protection and more people with antibodies out there. The third thing I would say about younger people, and just talking back to the vaccine hesitancy and this sort of 30-40% of our population, is actually, I think that they can be trailblazers. We've seen the queues. Many young people really are demanding that they, access to the vaccine now. And not only is it good for them, because I think that, they're at the forefront of social media, of thinking and so on. Not all thinking, perhaps I should revise that, but they're at the forefront of that kind of contemporary thinking and perhaps shaping certain views. But what I would also hope that they do is start to influence other people. If they have parents who are unsure, who haven't necessarily been themselves exposed to vaccines before, grandparents who haven't been able to access, I'm hoping that this generation is going to be able to really advocate for the vaccination program. Thank you. I'll hand over for the mortality, the more detail on mortality. I don't know who would like to handle that. Tumi, do you want to take that one on?
Maybe we can have Prof. Haneli speak to that. I think Flora touched on it briefly.
Yeah.
Prof, maybe you want to go into some detail, and other colleagues from NICEC maybe also want to do so.
Yes, thank you. I think it would be good if some of the other NICEC members can also add. But as I have already explained, what I can say about these cases, we give feedback to the person or the relatives involved, because it's personal information. So it's not information that we can make available to the public. But what I can say of these cases who we found to be coincidental to the vaccination, they all of them had multiple comorbidities. For example, diabetes, hypertension, coronary heart disease, or they had other diseases as well. For example, TB, HIV, and so forth. And the average age of that group was 70. So they were in the elderly age group, and unfortunately also, age is a risk factor for death. And then, as you've seen, some of them also had COVID-19 disease itself. So yes. So, but I leave it to some of my other colleagues to also add onto this. Thank you.
Is anybody going to add? Anybody from NICET?
So we've got a hand. It's Jonathan Peter.
Ah,
Hi, good afternoon. Can you see me?
we can. Thank you, Jonathan.
Yeah, hi, good afternoon, everyone. Yeah, just to add to Hanley, I think one of the things that I think, needs to continually be stressed, which we at NICEC have also been discussing, is the denominators and the background rates. So, if you looked in those deaths, how the causalities for the majority actually look coincidental. And I think one of the things, again, is we've never vaccinated so many people so fast. So if you look just in the over 60s, if at one point at several points, we've been vaccinating more than 50,000 people a day, which means in a simple month, you've accumulated, effectively 1.5 million people that have now been exposed to vaccines. And in the 1 month after that, just looking at the background mortality rate, you would expect potentially close to 170 deaths. That's the sort of figure that we worked out, almost 41 deaths a week. That would be within the kind of normal background rate within that age group, within that time frame. So I think that, that's why probably, we're very much encouraging people to definitely report all these deaths and to gather as much information as we can, especially allowing the autopsies to occur wherever possible, because this actually takes it from just a death where it's actually very difficult to assess the causality to actually look at a diagnosis or a cause of death, which then allows you to really interrogate whether there could be any association. So I think that would be my first point to make. And then just to add on to Prof. Reese's comment about the 18 to 35s, I think there's there's quite a lot of data now. And if you look at, there was a recently circular from the CBC that Kerrigan was actually sharing with us that has been looking, that has broken down cases from COVID, hospitalizations, ICU, death for every gender, for every age group, and then matched that up against the rates expected for these very rare side effects that have been identified, like for instance the Guillain-Barré, or for instance the TTS. And actually you can see from that data that in almost all the groups, the hospitalization and the death still leans strongly in favor of vaccination. So I don't think it's correct to think that it's correct to think that the case rates of hospitalization and death are much lower than in the older group, but they are not insignificant. And then I think the other point that Prof. Reese made is that none of this data even begins to factor in long COVID or the sequelae of COVID that we are certainly seeing with a very high rate in the young population. And so I think that data on the efficacy of vaccines to prevent that kind of illness, which is not potentially captured in the hospitalization or the death data, I think that's also something that needs to be stressed. Thank you.
Thank you. Kerry?
So thank you, colleagues, for the opportunity to address some of these questions. I'd like to add to Prof. Mayer's explanation that of the process regarding how the deaths are investigated and how any, in fact, of the serious adverse events are investigated. We rely heavily on the clinical notes that are recorded by the attending clinician in the doctor, whether it's the public or the private sector. And these then make their way with the forms that Prof. Mayer shared with us and come to the committee for an evaluation. Now, unfortunately, many times the clinicians do not know in advance that the patient may pass away. And therefore, the kind of data that is available to us when we evaluate the patient in the case of a death is limited to, firstly, what tests were done prior to the patient dying, and secondly, to the results found during autopsy. Sadly, many families are reluctant for their loved ones to undergo autopsy for understandable reasons. And that then limits the available information that the committee has to work from to the investigations that were done before death. And you can imagine how difficult a problem this is if an elderly patient at home who has been on diabetes medication and hypertensive medication, feeling a little unwell, and the next morning is found dead in the bed without seeking health care. then the problem is even harder because we have quite limited information on which to base a sound judgment. That's not to provide any excuses or a way of segueing out of what remains a very important question and a public health duty and responsibility to the people of South Africa to adequately assess and look for signals. Prof. Meyer could also share more information around the African collaborations that we have in terms of looking for signals around certain key adverse events, so as to maximize the data set or the denominators of people and to maximize the number of doses that were administered so that we can gather together more information around possible signals and risk factors. Thank you.
Thank you, Kerrigan. So let's move on to more questions. I know that you may have been on deadline. If you want this recording and the release, please share your email address with Mbali. I put her name, her address in the chat box so that we can get that to you ASAP after this. But let's move on to Nelisiwe Msomi from News 24, who's asked that if only reported data, you say that this is to prevent fake news, but are you not concerned this may have the opposite effect? Nelisiwe, I'm assuming you're talking about the microsite itself. You know, she's saying we have seen how certain elements are using reported data to further anti-vaxxers' agendas. Using the data that has not yet been verified by authorities to confirm links to actual side effects or deaths. So just talking about what you hope that this site will achieve, obviously. Second question is, what is SAHPRA doing to prevent anti-vaxxers from using this data to promote fake news about the vaccines? And the third question, what lessons are you drawing and implementing from VAERS in the USA and UK? Thank you.
Thanks, Leanne. I'm happy to maybe start with some of these. So, I mean, in terms of what do we expect to achieve with the site, and, you know, we could have gone the route of just issuing a press release and sharing this information, but we thought there is a tool that we can use data that the public can really disengage with that tool whenever you know, required. This is also a site that will be updating regularly, and so you will be seeing updates even on more, you know, as we vaccinate more and more individuals. And so what we aim to achieve is really to educate the public, but also to empower, you know, yourselves as media with at least the details around how we go about this exercise. In terms of our response with the anti-vaxxers, you know, our view is always people are hesitant when it comes to certain health products because they don't have sufficient details on them. They don't know enough. And so as SAHPRA, we've taken the view of saying we need to communicate. We need to educate. And, you know, utilize various platforms to ensure that we communicate, you know, these messages to a broad range of stakeholders. And, you know, those of you who are working with radio stations or television stations, you know, that utilize our local languages, again, we would like to, you know, have you reach out to us because we also want to communicate these messages, you know, to the rural communities that may not necessarily understand the English medium of conveying these messages. So really, we do believe that by the public getting the right information with the correct facts is really going to assist. Thank you. I'll pause here, and then I don't know if the other colleagues want to take other questions.
Maybe to answer what lessons we're learning or drawing from the US and the UK.
Oh, yeah, sure. I'm happy to look at that. So, I mean, we are, as we indicated earlier, you know, we are looking at largely what other regulators are doing, but we're also looking at what others who are collecting this information, how they're utilizing it. but we are very cognizant of our local context, and then saying, let's ensure that we create tools, we create communication platforms that are relevant for our local context. So we continuously assess what's happening in various platforms, not only the specific verse side. Thank you.
Thank you, Tumi. So this is from Linda Nesbitt. Unfortunately, she hasn't indicated which organization she's representing, but she's asked, is information on the use of COVID-19 vaccines in pregnant women available in the FAQs? Mafora, maybe, do you want to take that question?
I'm happy to take that one. I'll have to think hard, and maybe Flora can assist. I'm not sure about the FAQ, but we did issue a publication, on our website not so long ago in terms of use of vaccines for publication. And I see Helen's hand is up, and there's actually a lot of research going on in this space, and Helen will go into a bit more detail, but our view also continues to be that benefits of getting a vaccine, still outweighs the risks of a pregnant individual contracting COVID. But I'll let Helen maybe go into a bit more detail around that. Thanks, Helen.
I think it's a really good question. We are getting a lot of, especially now we're going down to a younger age group, we're getting a lot of questions about, I'm pregnant or I'm wanting to get pregnant. Is it safe? Will it cause infertility? I mean, there's a whole range of reproductive health questions, but if we deal with the pregnancy first, I'm also on the vaccine MAC. And in fact, at the moment, I'm just updating to the third version, an advisory on use of vaccines in pregnant women. So to say to everyone here, first of all, although pregnant women were excluded from many of the early clinical trials that looked at efficacy, inevitably there were some women who were either in early pregnancy or became pregnant soon after receiving vaccines, and that data has become available, and there were no safety signals in that data. In addition, because many Western countries rolled out vaccines before us, they've been able to collect data on women who've had the vaccine during pregnancy. And again, we haven't seen any safety signals. And clearly the kind of safety signals we're worried about would be fetal abnormality or an adverse obstetric outcome. What we are seeing, and with Delta this data is growing, is that the risk for pregnant women, although still small in terms of severe disease, is higher than for a non-pregnant woman. Specifically, pregnant women are more likely to require ventilation and to get severe illness, and more likely to have preterm labor and possibly a couple of other obstetric complications. I want to stress that this is with COVID infection. Sorry, this is very clearly with COVID infection. I want to stress that even with COVID infection, these risks are not huge. I don't want pregnant women to get very anxious if they get COVID, that this is a risk. But those risks with COVID infection are significant. And at the moment, our recommendation in South Africa is that pregnant women should be vaccinated with the 2 vaccines we've got. We'll be looking all the time at all of the global data on safety in pregnancy. And if we introduce other vaccines, we'll have a similar review. Just a quick word on infertility. I know that rumor is doing the rounds. There is no evidence to support a risk of infertility. One of the possible sources of this early on was from animal studies, early studies done in rats, where they gave 1,000+ times a dose of the vaccine, and they were able to detect the vaccine in the genital tract. But beyond that, there has been nothing. In fact, other studies have indicated, one small study with in vitro fertilization, where gynecologists looked at the outcomes of women who'd been vaccinated and women who hadn't, who had in vitro fertilization. Both were equally successful. So there's nothing that we've got at the moment that is causing any concern around infertility.
Thank you, Helen. If you could just stay on the line. The next question was addressed to you from Adele. She's asking about the current discussion among top scientists in South Africa and internationally, is that with the Delta variant, it's unrealistic to expect to reach population immunity, and that we should rather think about living with the virus as we do with the flu. What is your comment to this?
Yes, and this is getting a lot of discussion, because if you remember, when we started, we were all talking about herd immunity, and with the ancestral, the original virus, we were saying, oh, about 65% protection, that might do it. We'll stop the transmission of the virus. But now we know that's not correct. And one of the reasons, as has been said, is because the Delta variant is much more transmissible. And that means what it's going to do, it's going to find those reservoirs of people who don't have antibodies. And I think that nowadays, you're quite right. I think what people are really asking when they ask about herd immunity, and you know, do we need to get that to get back to normal? I think what people are asking us is, when can we get back to normal? When can we start to have soccer matches again with full stadium? You know, when can we start to do that? When can we, you know, take off our masks without anxiety? When can we do that? What do we have to achieve? And I agree that that because of this transmissibility, that has become much more difficult, because we need to have this population immunity. As you've seen, we've said it's got to get higher and higher and higher. But getting back to normal is possibly something that's somewhat different. If we can protect the majority of our population at fairly high levels, and through vaccination, but as I say, there'll be elements of that will come from natural infection. And if we can really start to slow the transmission of this virus, start to slow the number of people that are infected by one infected person, if we can bring that right down to under 1, then we can start to see a more normal society and start to really relax things. But you're quite right. I think that the view at the moment is that we are going to be living with this virus. What we're hoping with is that in time, that if we can control the emergence of variants, that's another reason for trying to lessen the transmission, because if we can lessen the transmission, we'll curtail the emergence of variants. If we can control that and we can get a level of protection in the population up, then we should be able to have, we probably will have a virus that circulates, but might well not be as cause the kind of pathology that we're seeing at the moment, that we can protect the most vulnerable. If you look in the UK, they've been incredibly successful at immunizing at hugely high rates. They're over 70s, 80s, and 90s, some of the most vulnerable. If we can protect the most vulnerable, then I think we can start to see and answer that question of we can move back to a more normal society, notwithstanding that we do anticipate that this virus is going to be with us, and that we might have to keep changing vaccines and adjusting them depending on the kind of variants that we see emerging.
Prof. Burnett, I know you had your hand up, please.
Thanks very much. Sorry, I can't show my video. It's on my laptop and I need the big screen so that I can read what's in the chat. Just to get back to the question about what is SAHPRA doing to prevent anti-vaxxers from using these data to promote fake news about vaccines. You know, we do know that they are going to be using these data. I can assure you that, you know, from past experience, they are going to be using these data. And I would suggest to SAHPRA, I see they do have very nice little pop-out boxes that you've actually got to close. And I suggest that they have that on each of those screens where they speak about, you know, all of the reports. I noticed on the one, it was right at the bottom and it wasn't a pop-out box. I think that pop-out box could, you know, just be large and it could be visible, and that you have to close that pop-out box before you can actually access, you know, what's underneath it. Because when these anti-vaxxers do, you know, report and misuse these data, they are going to have to give the links. So when the public go to the link, they will see that pop-out box. And I think that is one way that SAHPRA can actually stop the misuse of the data. Thank you.
Thank you, Prof. Does anybody else have any answers to those particular questions? Because I would like to move on to Valeli Ngidi. He or she is from the Department of Health, and he's asking, would we be able to triangulate Home Affairs deaths register and EBDS data as an additional layer to tracking mortality post-vaccination?
Marion, I don't know if you can take that one.
Yeah, good afternoon, everybody. So currently, the system to link EBDS data with Home Affairs doesn't yet exist. It might exist in future as we try to strengthen our health system and as we move to NHI, but currently that functionality doesn't exist. But I mean, we understand that people, there is natural death that occurs regardless of vaccination. So currently there is different sources of data that is being triangulated to look at breakthrough infection using the hospitalisation data and the death data, COVID positive data to triangulate. But for now, we are depending on people that suspect that an adverse event has resulted in a death of a family member to please report the adverse events as they occur. Thanks.
Dr. McCarthy?
Thank you for that question. There is indeed an initiative led by the South African MRC Burden of Disease Unit and Harry Moultrie within the NICD to do exactly that, to triangulate various data sources to strengthen our interpretation of the death data. Thank you for that question.
Thank you very much, Doctor. And here's a question to SAHPRA. So to me, I suppose this is to you or Helen. Is there a special alert to screen for pericarditis or myocarditis rare side effect in the younger age group now that we have opened up for 18 to 34, at least to alert them what to look for since they are more vulnerable to this serious SE based on evidence in the US? Thanks.
Thanks, Leanne. We hadn't put anything like that in place, but we will engage with our colleagues at NICEC to see if we can, but no, we hadn't. I mean, and I see Prof. Blackman also wants to come in to assist, but no, nothing particularly. But what we will be doing is also sending out just information to educate the public on these, rare side effects, particularly wherein we start to report on those once we've done the causality assessments. But Prof. Blackman, who's the chair of our pharmacovigilance committee, wants to come.
Also, thank you very much. What we've done is we've taken note of the very rare risk of myocarditis, and we've brought out initially to the healthcare professionals a memorandum, a dear healthcare professional letter, a document describing the risk and making them aware. And then the next step would be to bring out an advisory to the public, which is balanced without making people fearful of this very rare risk as well. So I think it's just to reiterate, it's a very, very rare risk, and we have made sure that the healthcare professionals out there are aware of that. Over.
Perhaps I could just also add, this is one of those risks that you need to also weigh up against the disease, because the risk of myocarditis with COVID-19 is really quite significant. And in screening, Jonathan mentioned the long COVID. I mean, it's one of the things that has been picked up in screening of some of the long COVID patients, certainly. But the risk of myocarditis in the disease is infinitely higher than it is with anyone receiving the vaccine. The other thing to say is that the one report that I certainly saw, which is I'm sure what is being referred to, was that the risk after the Pfizer vaccine was about 40 per million, all of which were self-limiting and gave quite mild symptoms such as a bit of shortness of breath or chest pain. And that's not to in any way diminish it. And Mark's quite right. We need to make sure that that's the transparency. Here's a risk. It's a very, very small risk. the risk of the disease in terms of what happens to hearts, and including young, fit people, is much more significant.
Professor Meyer?
Yes, thank you. In addition to what my colleagues now said, I think that's why it's so important to educate the public, and that's also where the media can help, is that people shouldn't, assume that the adverse effects that they are experiencing are just, because of the vaccine or something else. So if there's anything of a concern, they should report it. And what we have seen is that people would experience adverse effects and then they will not report it. And then they, it could end up with something a lot more serious. So as Helen has also said, these are very, very rare. But in most cases, if they are being reported and handled, fairly quickly, then they can be managed very well. So it's important to make sure that the message actually reaches the public. Thanks.
Thank you, everybody. Prof. Kerrigan is Dr. Kerrigan, sorry, has also put a link for this. If you want to follow it, it's on the chat box. Are there any other questions from the media? Oh, yes, one more. Nelisiwe Msomi once again says, we have doctors in South Africa who are anti-vaxxers and are claiming to collect data on the adverse effects of the vaccines and have people reporting to them so that to the so-called deaths from the vaccines. How will you take them to task? What consequences can they have for collected, unvetted data? That's quite a loaded question. I'm not sure who wants to answer.
Thanks, Leanne. I'm sure the colleagues have seen that the HPCSA is looking into this matter. And so as various stakeholders, we are, all working together to ensure that we communicate the facts when it comes to these products. For us as a regulator, we're very confident of the vaccines that have been authorized by SAHPRA. As we continuously say, we look at the safety, quality, and efficacy of these vaccines, and you can see that we are monitoring the side effects of these vaccines, quite closely. So I think the public should have the confidence in the various institutions that are, working around the clock and collaborating to ensure that we provide the public with products that are safe and that we monitor these as indeed these are new products. And so, as I indicated, the HPCA is looking into some of these matters.
Thank you. Another question. Please, can you share the link to accessing the dashboard? I think the link is available, Vilili, in the press release which we are issuing. If you provided us with your email address, we can share that with you. And Dr. Burnett, Prof. Burnett, sorry, has also put on another link. So please just monitor the chat box. Any other questions? Because, please, I see two hands up. Please go ahead.
It's Helen here. Just to add to this question about senior health professionals and colleagues who are coming out with these very strong anti-vax statements, just two things to reflect on. And perhaps it would be a good document, and sorry, I haven't got a link to give you, but if you look at, WHO has got a very good document on vaccine hesitancy and how to respond. And one of the issues is that if you're like the vast majority of clinicians and public health experts in the world believe in the effectiveness and importance of vaccines, what we mustn't do is actually start to repeat these anti-vax sentiments ourselves. What we have to do is to put the alternative view And I just want to, just was reflecting on this, you know, I'm reminded, I've been around a while, I'm reminded of HIV denialism. And so one thing I'll reflect to you as journalists is I remember very distinctly being on, say, radio interviews with somebody who was an HIV denialist, who had a lot of evidence that they were presenting. And what happens is it becomes like a one-on-one tennis match, boxing match between somebody who says and someone else saying I don't. And so the ball goes backwards and forwards and backwards and forwards. And the fact that actually, I would say, in terms of understanding of vaccination and its importance, in the corners that we're all in, as clinicians, as researchers, as public health officials, that we represent 99% of people who are working in our space as professionals. But we're often put as if the evidence that we're sharing and the views that we're sharing are equal. And that, I think, is often a problem. And that's also what tended to happen in the early days of HIV denialism. And it becomes very difficult because then it becomes, I said, he said, she said, or she said, whatever it was. So one of the things I would say as media is we need to say, well, where does the bulk of the evidence come from? What is the bulk of the viewpoint? And how are we making sure that we reflect the bulk of that viewpoint and not giving equal time to sort of views that say that there are certain components of a vaccine that have X, Y, and Z in it, when we know very well that all the regulators in the world are looking at those components and are very clear what's in it. So it's the sort of appeal, it's a difficult one, but that we don't give equal weight to very spurious ideas when the bulk of public health and epidemiological evidence rests elsewhere.
Thank you, Professor Burnett.
Thanks. Other than the reporting, I've given two places, you know, where you can report, you know, people who spread misinformation. And also obviously the Health Professions Council and also the South African Medical Association as well. There's a very useful WhatsApp group, and I think it's run by the National Department of Health. I'm not 100% sure if it is, but it's called I Choose Vaccination. And it's really very helpful. It's, for instance, has got that video of Mark Mendelsohn, you know, his message about, you know, his opinion of these, you know, medical professionals who are discrediting vaccines. And, you know, I really urge the media to actually follow or try and join it. I can't, unfortunately, invite you because I'm not an admin of that WhatsApp group. I'm trying to find a permanent link, you know, that I can share with my network. But it's really a very helpful WhatsApp group. They post probably 4 or 5 times a day with really useful information that you can use to flood the social media, excuse me, with really positive, you know, vaccine messaging. Thank you.
Thank you, Professor. We have a question from Sunday World, Sumaya Stockenstrom. She's asking whether we will see vaccines rolled out to children in the near future. I assume, Sumaya, you mean under 18. Prof. Burnett, you can respond. To me?
Thank you. Yes, I mean, you've seen in other countries that, you know, that strategy has already been rolled out as the various manufacturers have demonstrated data that these vaccines are safe and they're effective in that cohort. In South Africa, I mean, there is a discussion at the VMAC level, but also we've received data from Pfizer, you know, around the use of the vaccine for those who are 12 and above. And so we're currently reviewing that. So there is a lot of discussions locally around that. But I think that the large focus for now is really around, you know, as of today, it is the under 18 and above. Let's increase those numbers. But indeed, there is preparation to say that the time for us to need to vaccinate that cohort is slowly approaching. And so we need to ensure that we are ready and prepared for that. And as a regulator, we're looking at that data. Thank you.
Anybody want to answer as well? Okay. Any other questions from members of the media? Right. So as I've indicated, there is a release that we are sharing, and we will share this recording as well. Please just email my colleague Mbali. I think you have her email address so that she can be sure that you do receive the release. If there are any requests for interviews, please direct them to us. You will appreciate it is Friday afternoon, so that might prove a bit more difficult to facilitate. But thank you very much. I want to say thank you very much to everybody. I'm going to give Professor Reese, Professor Meyer, and Tumi an opportunity to thank and to say closing remarks. And then just thank you for joining us for this very, very important briefing.
No, thank you, Leanne, and thanks for facilitating this discussion. Really a stellar job. And thanks, for the questions that we have received. As indicated, we are available, for further questions, and we would like to partner really with the media to ensure that we send out the right message and we educate our public and really equip them with, correct information. Thank you.
Thank you. I'll back to me up, and I also, on behalf of the SAHPRA board, would like to thank everyone else on this team who's done so much work in this field, because I think it's incredibly important. The one thing I would say, because we have media with us, is just to reinforce this idea that can we think more creatively how we target different groups. I'm sure we've all seen the Nando's advertisement about, we do want to put chips in you, eat Nando's. I think creative messaging for different target groups, particularly as now we've got 18 and above, we have rural, we have urban, we have such a diverse population now. If you all could think about how can we target groups, how can we build confidence, because we do need to get the numbers up. But thank you so much.
Yes, thank you very much. I absolutely agree with what Helen has said, that we need to target the specific groups and, give them information and tools that will actually appeal to them. So one of the WHO recommendations is to actually vaccinate people with positive and good information. And I think that is what we need to do now. So I think that's where the media can really come in and help and assist with making sure that we give out the right information. So if you look at all the surveys, one of the most quoted concerns is always vaccine safety. So we need to try and instill that confidence in people about the safety of the vaccines. So yes, like Helen also said, look carefully at the headlines so that, we make sure that we get the positive information out there, and then to encourage people to report so that, to create awareness. So there's still millions of people not being aware of how to report and where to report and when to report and why to report. So I think that's also information that we need to get out there. So thank you very much to everyone for the interest, and yes, thanks.
Thank you, everybody from the panel, the speakers. Thank you for your time. Thank you, members of the media. Have a good day.
Bye-bye.